I will introduce Dr. Chughtai. So Dr. Bilal Chughtai is an associate professor of urology at Weill Cornell Medicine and an associate attending urologist at New York Presbyterian Hospital. Dr. Chughtai specializes in voiding dysfunction, female urology, and neurourology. He is an active researcher, has published over 160 peer-reviewed articles, authored chapters and books, and has presented at numerous prestigious national meetings. Thank you so much, Dr. Chughtai, for joining us this evening.
Well, thank you for the opportunity to present. And as Jyoti has mentioned, feel free to ask questions as we go along, and I'll give us an opportunity to keep this interactive and engaging. So to get started, these are my disclosures. Okay, so what we're going to go over, we're going to talk about the definitions and prevalence of overactive bladder. We're going to talk about management styles, what's the first-line therapy, second-line therapy, third-line therapy, which includes PTNS, sacral nerve modulation, and Botox. And we'll look at special populations of how overactive bladder can specifically affect the elderly, as well as its effect on depression and anxiety. And we're also going to talk about a paradigm shift with a novel product, obviously using Flowins as well. So first question is, what is overactive bladder? So the International Continence Society, where it's a group of experts, came up with a definition, so at least we have a place to start. It's urgency with or without urgency incontinence. In other words, leakage of urine, usually associated with frequency of urination and nighttime urination. What are the key symptoms? This includes frequency of urination, so greater than 8 urinations in a 24-hour period. Urgency, which is a sudden compelling desire to urinate, which is difficult to stop. Urgency incontinence, which is the involuntary loss of urine, sometimes requiring the wearing of pads, and nocturia, which is waking up 2 times at night to urinate. So we have to first start off with defining what is the condition. Now, keep in mind that lots of things will cause people to urinate more frequently. Like, for example, if you're consuming lots of water, right? If you're consuming, let's say, for every 1.5 to 2 cups of water, you are going to urinate probably once, right? And if by consuming less water, right, the condition goes away, that's not overactive bladder. Typically, by changing the diet, the symptoms don't necessarily go away. But despite changing amount of fluid intake, if there's still lots of frequency, lots of urgency, that's what we call overactive bladder. So one thing that's really important about this condition is that patients with overactive bladder and incontinence of urine do not seek medical attention, and they opt to suffer in silence because a lot of times they think it's a normal part of aging. That's one. And two, they don't realize that there's treatments that are available. And last part is a lot of times you'll see, like in the pharmacy aisle, you'll see pads and people just go, oh, it's just a natural part of aging, and that's it. A lot of patients will suffer an average of 5 to 7 years with this condition prior to seeking treatment. So how does it affect the quality of life? There's psychological aspects, which can cause depression, lack of motivation. It can reduce work productivity when you're looking for bathrooms. Obviously, there's the cost associated with pads. Patients tend to isolate themselves because they have anxiety, fatigue, social isolation. They stay away from sports to become more sedentary. They are unfulfilled by not doing hobbies and able to travel. Obviously, if you're worried about incontinence or leakage episodes, it's hard to be sexually active, which leads to lower libido. And when it comes to daily life, there's a negative impact when it comes to hygiene, sleep, as well as the ability to do household duties. So who's affected by this? Nearly 1 in 4 people are affected over the age of 60. There's about 50% of men and over 50% of women between the ages of 40 and 59 are experiencing some overactive bladder symptoms. And urgent incontinence and overactive bladder are the most common cause of urinary leakage in the elderly. It's possibly a marker even for frailty, in other words, how weak people are, and it's also linked with cognitive impairment. Now, it's hard to say what comes first. Is it the incontinence or the cognitive impairment? But we know they're uniquely linked. So the idea is that we want to address this condition because of its effect on quality of life, on sleep quality, as well as energy levels. So when you first go see a physician about this condition, you want to make sure they recognize the urinary symptoms. You want to assess how the symptoms are consistent with overactive bladder, their severity, impact on quality of life. You want to conduct a physical exam, specifically a pelvic exam. You want to look for things like pelvic organ prolapse. You want to look for vaginal atrophy. You want to see if there's leakage with cough, lapse, sneeze. You also want to identify comorbidities that can worsen this condition, like diabetes, dementia, depression, prostate bladder cancer in men, enlarged prostate in men. You want to list the current medication, because sometimes medications like diuretics can lead to a significant amount of worsening of urge incontinence because of the significant production of urine in a short period of time. And when patients are aware of this, you can help guide when to take their therapy, sometimes in the morning, early afternoon. You want to perform tests like urine analysis to rule out blood in the urine, urinary tract infections, and you want to assess for other conditions that can lead to these symptoms. So how do you assess for this? Keep avoiding diarrhea. Avoiding diarrhea is the mainstay of defining overactive bladder by documenting urinary frequency, incontinence episodes, as well as fluid intake. You want to have some questionnaire to assess the impact of quality of life. A lot of times a simple question about, does this condition bother you? Can you live with this bladder condition for the rest of your life? That can also help you understand how much this condition bothers you. Because you'd be surprised at how many patients will go, actually, this is pretty terrible, and I'm looking for a solution. So again, ask questions about an uncomfortable urge to urinate, a sudden urge to urinate, accidental loss of small amounts of urine, as well as the nighttime urination, specifically nocturia. So when we talk about first-line therapies, this should be offered to all patients, regardless of how severe the symptoms are. Think about bladder training, Kegel exercises, time voiding, biofeedback. You want to moderate excessive fluid intake. Now, actually, Josie and I were having a discussion right before this about how much is the appropriate water intake for a person, right? And we know that if we feel dehydrated, right, we can get low amounts of energy, right? And you can feel pretty weak. You also have increased risk for urinary tract infections. By having appropriate amounts of fluid and having a moderate fluid intake, you can reduce those side effects as well as improve your overall bladder health. Think about dietary modifications by reducing bladder irritants like spicy food, acidic foods. Now remember, the goal here is not to torture the patient by taking away foods that they love, but understanding how certain foods like caffeine, spicy food, acidic foods can cause more urgency frequency. We also know that weight control or reducing waist circumference can help reduce urinary urgency and frequency as well. Also, educate patients. You want to set realistic treatment expectations. In other words, no matter what treatment you offer patients, they're not going to have the same bladder that they had when they were 20 years old. You want to talk about percent improvement, like, hey, I expect to have 30%, 50% improvement. You want to provide information, resources. And for patients that are older or have difficulty with mobility, think about other accessories, things like a commode next to the bed, as ways to prevent falls when they're having frequent toileting or you're working on reducing their nocturia episodes. And remember, first-line therapy can be combined with other overactive bladder treatments and should be part of any treatment plan. And not any, every treatment plan. Now, when you give the second-line treatments, there are really two mainstays of treatment. One is anticholinergics, which has been around for a long time. They inhibit the muscarinic receptor. They prevent the bladder from squeezing. So it's basically the M3 receptor, which then prevents the bladder from squeezing, right? Which reduces the overactivity of the bladder. Now, keep in mind with anticholinergics, they've got some significant side effects. They have dry mouth, constipation, as well as a link with dementia. So this is a drug that you want to use with caution. And whenever you're prescribing this drug, I try to tell patients to be watching out for these symptoms. The other part is a lot of times when patients get dry mouth, what do? They drink a lot of extra water. When they would drink extra water, it sometimes exacerbates their condition. The constipation has a very similar side effect as well. So you want to warn patients ahead of time to think about sugar-free candies to help increase saliva production. Also, avoiding constipation with stool softeners as opposed to excessive fluid intake. The other type of therapy is called beta-3 agonists. The first one came out in about 2012, which is mirabegron, and then there's subsequent other therapies like virabegron. Now, what these do is they work on the beta-3 receptor to allow the bladder to passively expand and hold more urine. So they don't affect the bladder's ability to contract, which is important for men, especially because if the bladder can't squeeze and they have an enlarged prostate, it can sometimes make it so they can't urinate at all and cause urinary retention. This is less of a concern with women, but it can also lead to incomplete bladder emptying with anticholinergics, which is not a concern with beta-3 agonists.
Dr. Chughtai, I have a couple questions here regarding treatment. So any role for beta blockers in OAB?
Not beta blockers. So beta blockers, right? So when you talk about beta receptors, right? So there's beta-3 receptor, and there's beta blockers. So beta blockers affect the blood vessels and the blood vessels' ability to dilate and contract. So beta blockers don't affect bladder contractility, but beta-3 agonists are very specific to that receptor in the bladder, which help reduce urinary urgency and frequency.
Thanks. And then one more here. Older adults commonly have increased frequency and urgency overnight, but not during the day. Any advice for treatment? This is after we work on Kegels, biofeedback, decreased fluid intake before bedtime, and decreasing bladder irritants.
Yeah, so I would say when we're talking about the condition nocturia, and unfortunately, nocturia by itself is its own talk and its own entity. It's multifactorial. So it could be from the factors of you can have overactive bladder, and the thing is that sometimes during the day we compensate really well for it. We can also have nighttime smaller bladders, right, which leads to more urgency frequency at nighttime. You can have nocturnal polyuria, where your kidneys just produce too much urine at nighttime. You can also have other sleep conditions, which lead to like sleep apnea, which leads to overproduction of urine as well. So the bladder diary can be really helpful to figure out which one of those 4 conditions are existing to help guide therapy.
Awesome, thank you. And just one more question here, actually. What is first go-to therapy for OAB for middle-aged men?
Great question. So I'm going to go back a slide and go back to first-line therapy. So every patient should be started off with first-line therapy. So before you get into medications, think about behavioral therapy, lifestyle changes, education, and toileting assistance for elderly patients. So always start off with that. Obviously, we're going to talk about some, a novel supplement, Flowins, and we'll talk about how that can play a role, but also medications is obviously second-line therapy.
Great, thank you.
All right. So when you talk about anticholinergics, we know they have a variable side effect profile. So when you look at the adverse events for these medications, we can see that antimuscarinics, especially when we get into comparing these drugs to looking specifically at dry mouth constipation, they have significant side effects. And obviously, the more non-specific the agent, things like oxybutynin, have the highest number of adverse events related to the medication, versus when you get more and more specific, it becomes less often. But again, these are drugs that you want to be cognizant of, things like dry mouth, constipation, and the risk of long-term cognitive decline. Now, when we talk about treatment persistence, I think this is a really compelling slide, which shows that if we take a look at patients, right, when they're first prescribed the medication, and we can see this is out to 800 days, so roughly around you're talking about like 3 years, 3 years or so of therapy. You can see that roughly at the 3-month mark, there's a significant drop off in compliance. Now, the drugs that are anticholinergics have the most significant drop off, while drugs like beta-3s tend to have less of the drop off. But again, you can see that the adherence to therapy is very, very low when it comes to second line therapy. And this is due to a multitude of factors, from inefficacy, side effects, as well as it's hard for patients to understand the fact that this is a lifetime of medication. You're going to be on these medicines forever. And for a lot of patients, that's a hard thing to do.
Dr. Chughtai, question regarding Myrbetriq. You did just mention that it's like a lifetime treatment, but the question also asks, how long does it take to work?
So mirabegron is one of the slower acting agents. In my experience, I typically find patients need to be on a minimum of 4 weeks to see if it's really helping. Usually 4 to 6 weeks gives you a signal. You need up to 3 months to see how well it's working. So it's definitely a slower acting drug.
Okay.
All right. So third line therapy, for those who have failed usually one medication, and then depending on insurances, it could be 2 medications. There's something called Botox, which causes, or onabotulinum toxin A. We'll call Botox going forward. It's for carefully selected patients who have inadequate response. They can do well with Botox. So it's a therapy that requires retreatment every 6 months, where you go in and have Botox injected into the bladder. And this leads to a neuromuscular blockade of the acetylcholine, and then therefore paralyzes the bladder. So in a small subset of population, I'd say around like 4%, the medication can work so well, patients have trouble urinating. There's also nerve modulation. Either this comes in the form of peripheral tibial nerve or sacral neuromodulation. So either the posterior tibial nerve is stimulated or the sacral nerve is stimulated. So what this really does is that this stimulates the nerves to the bladder, right, and reduces that signal to reduce urgency and frequency. Now, sacral nerve modulation is probably the most invasive of the third-line therapy, involving the permanent implant of a bladder pacemaker. But it's also one that probably has the most durable response in that a lot of these batteries can last up to 10 years. So when you talk about frail and elderly, remember you want to think about age-related effects on pharmacology. There can be changes in pharmacokinetics, absorption, distribution of drug clearance. They also can sometimes have drug that persists in the body for a longer period of time. The other thing is the concept of polypharmacy. It's very real. What happens is that obviously when our interaction checkers, like they're very good at checking a single drug, maybe even two drugs, but some of these patients are on 10, 15, 20 drugs, and it's hard to predict how those adverse events can increase exponentially with each additional medication. Anticholinergics, as we talked about, the cumulative use of these may lead to cognitive impairment, and high risk due to age comorbidities, drug metabolism can also cause further problems. So the last part is that also when you have these elderly patients, and I think this is really pronounced during COVID, when we all had those masks on, it was very hard for patients to hear and understand. And you want to tailor your communications to patients. You want to involve the caregivers to help sort of have a comprehensive plan in mind. So what is anticholinergic burden? It's a cumulative effect of multiple anticholinergics. It's associated with adverse drug events and negative health outcomes. So older adults may forget or they'll omit over-the-counter medications. They're also more sensitive to the anticholinergic effect. And you want to really weigh in that risk-benefit ratio and think about using an anticholinergic burden score so that you're evaluating the true burden on these patients so that we're not taking these patients and causing further cognitive issues over time. So when we're looking at the anticholinergic burden, we know that pharmacokinetics and pharmacodynamics change. So older people may be at increased risk for things like dry mouth, blurred vision, constipation, cognitive decline. And if you look at the European guidelines, they recommend long-term anticholinergic treatment should be used with caution in elderly women, especially those who are at risk for pre-existing cognitive dysfunction. And in addition to that, anticholinergic burden and associated comorbidities should be assessed in patients being considered for this therapy for overactive bladder. So you want to be very cognizant of this. And this is where I usually involve the patient, caregivers, as well as their primary care doctor to make sure that these drugs are being used appropriately. And as we know, there have been a number of reports linking anticholinergic medications to cognitive impairment. And there's been a recent study of over 40,000 patients aged 65 to 99 with a diagnosed risk of dementia, and basically showed that if you have an anticholinergic burden score of greater than 3, the link to future dementia incidence with an association persisting up to 20 years after exposure. So the idea is that you want to be very cognizant of this because unfortunately, as we get older, all of us lose some cognition. Some of us obviously are at risk for dementia as well. But when you're exposed to these drugs with a high anticholinergic burden, that risk becomes far more pronounced. So what are the psychological impact? As we briefly discussed, there's impact of anger, hopelessness, frustration, worry, anxiety, embarrassment. The whole thing is like if you're focused on having to go to the bathroom, it's very hard to focus on other things. And this also leads to patients literally almost confining themselves to their home to avoid these feelings and avoiding interactions with their loved ones or friends. And if we look at those who have overactive bladder, 32% of those with overactive bladder also have symptoms of depression. And this is based on a study of about 11,000 individuals. And those who have overactive bladder and depression tend to have more severe incontinence. So this is a study looking at 51 patients with overactive bladder. 27% had clinically defined depression, with more than 10% reporting moderate to severe depression. Basically, what they found was the worsening the overactive bladder and depression, they had worsening incontinence episodes. And as you have more incontinence episodes, it further feeds this vicious cycle with worsening overactive bladder and depression symptoms. So it's hard to say what comes first, but the idea is you have this persistent cycle that gets worse and worse over time. In addition to that, poor mental health can impact management of these patients. Both depression and anxiety have been found to have a negative impact on the perception of lower urinary tract symptoms, specifically overactive bladder. Many patients prolong seeking treatment, an average of 5 years, which delays in the initiation of management therapies. A lot of patients are embarrassed about this condition. In addition to that, poor mental health can lead to poor compliance and leads to patients who get less motivated and have further causes of depression. And this can definitely be very challenging for patients with overactive bladder. So the idea is that overactive bladder, when we take a look at this, it's a condition that's multifactorial and has tremendous impact on the whole body, and especially on cognition, depression, anxiety.
Dr. Chughtai, question here.
Yeah.
Does antidepressant therapy advance or improve OAB symptoms in any way?
There is so when we look at the antidepressants, specifically SSRIs, there is data to show that they can help reduce incontinence episodes, specifically stress incontinence episodes. Some of these drugs do have some anticholinergic properties, so they may help to some degree, but they're obviously not as effective as overactive bladder medications. But again, this is one of those conditions where you want to address that have a multi-pronged approach. So if you have a patient with overactive bladder and depression, they may benefit from dual therapy with an SSRI as well as an overactive bladder treatment as well.
Okay.
And when we get into patients with adaptive behavior, a lot of these patients will reduce fluid intake. They'll have emergency clothes, so they can't ever leave the house without planning for things. They're planning ahead with escape routes. And I mean, if you guys take a look, I know in New York City, there's literally apps that are available to help you identify where the nearest bathrooms are and how clean they are. So the point is, like, this is such a common problem that these people have a variety of escape routes planned. Patients can also wear incontinence pads, which can be irritating to the skin. They avoid intimate situations because they don't want to be embarrassed. And they also limit travel to places where they know where the toilets are. So how do we manage? So as we discussed already, we want to recognize the symptoms and impact on quality of life, apply the appropriate assessments with a physical exam, sometimes post-void residuals, urine testing. You want to treat initiates with behavioral lifestyle therapy, add pharmacotherapy as if it's required. You want to educate and motivate the patient about treatment expectations. You want to help patients take ownership of their treatment. And you also want to schedule appropriate follow-ups, because if you don't schedule appropriate follow-ups with appropriate assessments, sometimes patients just get lost being like, hey, this is the only thing the doctor had to offer me, and there's nothing else that's available to me. So what about new options? So this is a really exciting study that we published a few years back looking at the efficacy of a dried cranberry in women with overactive bladder. And this is a randomized, double-blind, placebo-controlled study looking specifically at the compound called Flowins. So Flowins taps into a growing consumer demand for non-pharmaceutical natural solutions that address urinary symptoms. It's produced from a sustainably grown cranberry and is sold with an ID pack to validate its botanical identity. Now, what I would tell you is, like, in my practice, what I've seen a lot of is that there are patients who have significant symptoms, but they don't want to be on pharmacotherapy for long, long periods of time because of the side effects and cumulative effect that it can occur. Now, when you get into natural solutions, a lot of them are very easy to tolerate, safe, and patients are willing to stay on them for a prolonged period of time. Now, in our study, we basically screened 118 patients, 98 were randomized, 46 got treatment, 52 got placebo, 36 completed the trial, completed the treatment arm, 41 completed the placebo arm, 11 were excluded due to non-compliant diaries and visits that were out of the window, and 25 were included in the protocol analysis, and 35 were included in the placebo analysis. What we found was for those who completed the study in our protocol analysis, mean age was about 47 for both groups. Mean weight was about 71 kilograms. Ultimately, we saw that there was not a huge difference in race between both arms. When we looked at mean daily micturition episode, we saw that treatment had about 12, and placebo had 11.2, and there was a lot of grade 3 and grade 4 urgency episodes as well as nocturia episodes. And we can also see that a lot of these patients did suffer from this condition for a long period of time, with an average of about 2 years to 2.5 years for the treatment arm. Now, when we look at changes in micturition, we can see that there was a decrease by 2 in micturitions. Now, this may not sound like a lot when you look at it on paper, but when you talk about patients and their degree of bother, there was a significant improvement in their overactive bladder short forms and also in their perceived bladder health as well. And finally, when we look at the subscores looking at urinary dysfunction as well as overall quality of life bother, there was improvement there as well. But ultimately, the big places that we saw improvement was in the number of episodes of urination and urgency episodes, as well as nocturia episodes. So all in all, this was shown to be almost as beneficial as beta-3 agonists as well as anticholinergics without the significant side effects that go with it. Now, when we look at specifically comparing Flowins to other therapies such as birabegron, mirabegron, and anticholinergics, we can see that the mean difference in micturitions was almost by 2 in the cranberry arm versus other medication. So when we looked at this population who had dry OAB, we can see a significant improvement in symptoms. In addition to that, the biggest difference that a lot of patients have reported, and I've seen this in my practice as well, is that they've had significant improvement in urgency episodes. So that sudden urge to urinate, the sudden compelling, desire that's hard to get rid of, improved greatly in this population. From this, we're able to show that daily intake of dried cranberry Flowins improved daily micturition episodes, urgency episodes, patient-reported bladder conditioning, as well as supporting its use as a safe treatment for overactive bladder. So when we talk about the overactive bladder treatment spectrum, we talked about how every patient should be on lifestyle modification. So weight reduction, reduced caffeine intake, stop smoking, bladder training, Kegels, limiting fluid intake to a moderate level, and regulating voiding on a regular schedule. We know the role of pharmacotherapy. We spoke about anticholinergics, its risk of dementia, as well as beta-3 agonists, how these are new novel agents. But you remember, when you're prescribing pharmacotherapy, be careful with polypharmacy. We know about the role of neuromodulation with peripheral tibial nerve stimulation, synchronous modulation, as well as Botox, and therapies such as augmentation, cystoplasty beyond the scope of our talk in urinary diversion. And that's pretty rare to utilize altogether. And what we're seeing here now is that we have a novel agent, Flowins, which really falls right between the lifestyle and behavioral approaches and before pharmacotherapy. This is something that we can offer our patients that will give tremendous improvement in quality of life, urgency episodes, as well as micturition episodes. So key messages: overactive bladder is prevalent. It affects 12 to 18% of men and women. It can have a tremendous negative impact on psychological well-being, overall quality of life, and physical health. So it's a really important condition to ask about and assess your patients for. There's a variety of pharmacological and non-pharmacological therapeutic options, and you want to discuss this with patients. And Flowins has very promising randomized controlled data for overactive bladder symptoms. Thank you. Happy to take questions.
All right. So we have a few questions here. Thank you for the talk. I quite enjoyed the question and answer kind of interaction throughout. So that was nice. So our first question here is, can you comment if there is any use? Actually, you know what? I'm going to go to another question because it's relevant to what you just spoke about. How do you take the dried cranberries, and how much and how often?
Yeah, so Jyoti, I think you can talk about your product here. I think we have the product that's available. It's a single pill that you take daily. It's appropriately dosed. And I've had lots of positive feedback from patients of taking it daily and helping it, and how it helps with urgency episodes as well as the number of voids per day.
Yeah, so exactly. So our bladder health product, and we can talk about it later on if he wants to hang on, but it's 500 milligrams. So that's the same dosage that was within the study that Dr. Chughtai covered. And it's just 2 capsules once a day. So pretty easy. Okay, so some questions here regarding treatment. Can you comment if there is any use of Flomax in treating OAB?
You said Flomax, correct?
Yeah.
Yeah. So Flomax is used for enlarged prostate, right? Now, when you talk about enlarged prostate or BPH has two big components to it: obstructive symptoms, in other words, weak stream, incomplete bladder emptying, and then there's also irritative symptoms as well. So it's not great for overactive bladder, but it can be really helpful for those who have irritative symptoms from enlarged prostate. But also keep in mind, 30% of men with BPH are actually misdiagnosed because they really have overactive bladder. So it's important that when you're treating men, some men will benefit from medications like tamsulosin, Flomax, but some would also, a lot would benefit from specific overactive bladder treatment.
Okay. How long does it take for Flowens to show results?
In my experience, I've seen it takes roughly around 6 weeks to really start working. So around 4 to 6 weeks, we start seeing a pretty strong signal of patients having improvement in urgency episodes.
Nice. Okay. And what are the side effects of Flowens?
In our study, we found very, very rare side effects. Basically, a few patients, I think it was like I want to say like 1 or 2% had some upset stomach, but that was really about it. And we had the same rate in the placebo arm, so it's hard to say if that was from just from a new pill, but all pills have some can have some nausea, vomiting that go with it. But ultimately, there was nothing specific to cranberry.
Okay. The question just came in that I'll quickly answer. Is it available in Canada? The answer is yes. Okay, so the next question is, if a patient has recurring UTI symptoms presenting with low colony count in the urine culture, would you consider antibiotics?
Different talk, but I would say that if you have low colony counts, I think it's important to work with your clinician there to figure out, is it like a negative urine culture versus if it's chronic bacteriuria. So I need to have some more information, but we want to avoid the use of chronic or long-term antibiotics, and we're always searching for more natural solutions if we can. But again, I would work closely with your physician to sort out what's right for you.
Okay. I saw a few patients were prescribed with tamsulosin and mirabegron together. Were the effects of each medication canceled out if those are prescribed together?
Yeah, so it's actually the opposite. They don't cancel each other out. It's almost like they supplement each other. So think of tamsulosin as reducing the outlet resistance at the bladder neck, allowing better flow. So it gets rid of the obstructive symptoms. Then you have the irritated bladder, the overactive bladder, where the beta-3 agonist allows the bladder to hold more urine, so they have more time to make it to the bathroom.
Okay. What about overactive bladder caused by a prolapsed bladder? Like what would be your approach in that instance?
It's a good question because pelvic organ prolapse can lead to significant irritative urinary symptoms, as well as the fact that patients with prolapse can also have overactive bladder. So I'm always a big fan of exhausting conservative therapies first. So I try to address the overactive bladder first. So these are the patients that will try things like Flowens or beta-3 agonists prior to a prolapse repair, or even try a pessary prior to repair.
Okay. Okay, we have a lot of questions coming in. Let me see here. Okay, you have not covered or discussed the psychological causes of urge incontinence, where incontinence happens 3 steps from the toilet.
Yeah, so I would say that when it comes to urgent incontinence it's very difficult, and there's many different names for what you're describing. There's something we call it like keyhole incontinence. So when you're putting that key in the door, all of a sudden you get that sudden urge to go, and it's very hard to sort of get rid of that. Also, there's when you turn on the faucet. So there's certain triggers that when they occur can lead to significant urgency. So I would say that that's where Flowens can really help with reducing those urgency episodes.
Okay. Can a diabetic patient take Flowens?
In our study, we didn't specifically exclude diabetes as long as it was well controlled. So as long as you have well controlled diabetes, there's no reason not to take Flowens. Now, keep in mind that if you have uncontrolled diabetes, that probably needs to be addressed because no supplement or medication, overactive bladder medicine, is going to get rid of the polyuria that occurs with diabetes.
Okay. Does Flowens or can Flowens help with stress incontinence, for example, post prostatectomy?
In the post-prostatectomy setting, again, slightly different, I mean, very different talk, but I would say that post-prostatectomy incontinence can have urge components to it and stress components to it, and stress-induced urge components as well. So Flowens can definitely help with the urge component of it, and maybe can help with some of the irritated bladder as well.
Okay. If a patient is managing without a medication, but it's still a bothersome condition for them, would it be better to take a medication? Patient is mid-40s.
Again, this is a condition, as we discussed, can lead to depression, anxiety, social isolation. So the degree of bother really dictates treatment, right? So I would say ultimately, that's why I think having this novel natural solution can be really helpful for these patients, because a lot of people don't want to be on meds forever, but Flowens could be an opportunity for us to get these patients adequately treated with minimal side effects.
Okay. Um, let's see here. What age group do you project early preventative measures? So males and females, would overactive bladder be considered genetic, running in families? So there's a couple of things here. Maybe if you can address, would overactive bladder be considered genetic or running in families? Is that something that you see?
There seems to be a genetic component to it, and we see it in practice too, where patients talk about things like, oh, my mom always ran to the bathroom, I always had to run to the bathroom, I've had this my whole life. So there's definitely a genetic component to it. It's not well studied though. As for preventing overactive bladder, we don't have great data on how we prevent it. Unfortunately, this is one of those conditions where we know who's more likely at risk, and we know it occurs more often as we get older, but we don't have great data on how to prevent it.
Okay. Um, going back to Flowens here, how does it differ from other like your regular cranberry supplement?
Yeah. So when we get into the supplemental market, this is actually a very, the best way to describe it, it's the Wild West, right? There's a lot of supplements out there, and we actually did a study probably 5 or 6 years ago where we looked at a variety of cranberry supplements. And what we found was that I think we looked at around 17 different supplements, and we found that actually 3 or 4 of them had zero cranberry in there. 2 of them had blueberry. And on top of that, a lot of them are not processed properly. So the whole point is that when you talk about a high quality supplement, which has its own high quality manufacturing that goes with it, I think that's what really makes Flowens a different supplement from the stuff that you pick up from typical, you know, health food stores. So again, high quality supplements are an important part of how we get adequate treatment.
Okay. Let's see here. Does Flowens have any drug interactions such as biologics?
It should not. In theory, when you get into cranberry supplements, and again, I think Derek is actually I see that he's putting it in the chat that there's always a concern with oxalates, and as Derek had mentioned, these oxalates are through the processing, the oxalates are removed, as well as the anti-thrombotic portions of it. So the parts that lead to increased bleeding and interaction with Coumadin are removed from the product. So it seems like they're pretty safe. But again, I would run that by your primary care doctor just to be certain.
Okay. Are there any comparative studies that you're aware of between cranberry and any medication? Like obviously for OAB.
Not yet, but that's something we're working on. So we're looking at trying to create real world studies to compare something like Flowens to Myrbetriq, Verbegron, and anticholinergics to help sort of come up with head-to-head data as opposed to indirect analysis, which is what we're doing now.
Okay. Is 20% retention of urine in the bladder high, and would Flowens help for this?
The answer is maybe, and the answer is maybe. Unfortunately, it's hard to say because that's it's only a piece of the pie. So when we talk about retention, retention means that your bladder doesn't fully empty. So it'd be important for us to understand why your bladder doesn't fully empty, and from there we could determine what would be the best way to address that. Now, if there is some component of urgency frequency, the flowins can help with the urgency frequency component, but it's not going to necessarily help from a mechanistic standpoint of improved bladder emptying.
Okay. So this is a great question. It is surprising that cranberry, which is technically acidic, does not aggravate OAB symptoms.
Agreed. Excellent question. And the answer is that we don't know exactly why cranberry works the way it works in overactive bladder. There's a multitude of mechanisms. Now, one of the theories is that there's the microbiome component of the bladder. In other words, what is good bacteria versus not so great bacteria. So certain bacteria like lactobacillus, we know can help reduce what's called like ATP. And ATP is what leads to increased bladder overactivity or contractility of the bladder. And there's other bacteria such as Gardnerella, which can increase ATP activity, leading to more overactivity. So it's likely that cranberry affects the microbiome of the bladder, changing that, and therefore making the urothelium less sensitive and less overactive. But we don't have an exact mechanism as of yet of why cranberry helps with overactive bladder symptoms.
Okay. So does everyone need urodynamic studies? Can we start medication without these urodynamic tests?
Yeah, so urodynamics, there's actually been urodynamics is a very interesting area because I would tell you at the AUA this year, American Urological Association meeting this year, there's definitely a push towards better diagnostics because we know that lots of studies have been done that show that urodynamics isn't the best at helping to predict outcomes or helping to predict what's the best treatment options. But urodynamics is probably the best test that we have prior to third line therapy. So in my practice, we use urodynamics a fair amount prior to third line therapy, but not before supplements or medications.
Okay. Do you have any data about the effect of flowins on IPSS scores?
In this population, we did not track IPSS scores, but there was a study done by Naturex, who produces flowins, and they did show a reduction of IPSS, I think by at least 3 or 4 points in men.
Nice. Okay. Does vaginal estrogen help with OAB?
So we did a study looking at the use of topical estrogens with anticholinergics, and we found that there is a synergistic effect between topical estrogens and overactive bladder treatment. So depending on the condition, because when you have vulvovaginal atrophy, that can lead to more irritative symptoms around the urethra, leading to more urgency frequency. So depending on the condition, it can be helpful. But again, vaginal estrogens don't come without risk. There's a theoretical risk of increased risk of breast cancer and uterine cancer.
Okay.
But again, if you look at the data from OGS, they show that the systemic absorption of the estrogen is very little in that population.
Okay. Does IR radio frequency technology help OAB in women?
Are
Are you familiar with?
I assume you mean RF, which is radio frequency. So there was some studies done on the use of radio frequency ablation of portions of trigone and nerves, but there isn't great data on its use yet.
Okay. Is it actually no, we already covered this one. Okay, if the condition isn't severe, can we start with, you know what, this one you've answered as well. It was saying if the condition isn't severe, can we start with the natural product before initiating prescription drug? But the answer to that is, I'm
Absolutely.
assuming yes,
Yeah.
right? Okay. What causes the stopping and starting when urinating?
Yeah, again, that's what we call a lower urinary tract symptom, and that's incomplete. That could be a combination of incomplete emptying. So it could be a bladder that's overactive, it could be a bladder that's underactive, it could be related to the outlet or urethra where it doesn't relax completely, or it could be the fact that the bladder is just very irritated, leading to incomplete emptying. So a multitude of factors can cause stop and starting of urination.
Okay. So you did cover earlier a question regarding the benefits of SSRIs um, for patients who have anxiety or depression and OAB. Are you familiar with any studies that look at this?
There are studies looking at stress incontinence and SSRIs, but there isn't like high quality studies done with overactive bladder though.
Okay, see here. Okay, so I'm just going to read this out for you. So, patient, the Kegel chair, supplementation, reduction of fluids later in the evening, these will all help reduce OAB and early detection. But for early treatment, does this equal early prevention? And should we be treating, say, a 30-year-old more proactively?
That is a excellent question, and the answer is we don't know. Unfortunately, when it comes to overactive bladder, we don't have great data to show that earlier intervention leads to better outcomes. But it probably makes sense that if you're starting earlier on the algorithm, maybe that could slow the progression of the condition. But we don't have great data on that.
Okay. A question came up earlier, not necessarily a question, it was a comment, but I think it was interesting to maybe bring up this in the discussion. Um, the the person had just made a comment about how, there's a lot of men who have OAB, but they don't talk about it. And so they go quite undiagnosed. Do you have anything you can share, maybe like some tips or like, when primary care practitioners are speaking with men, how to kind of get that information out?
Absolutely. So I think again, I think it's important to ask about urinary symptoms. I think it's important to ask about is there specifically incontinence episodes? I think a physical exam is a great way to pick up on that as well. And in the chat, I'm seeing a comment on vaginal estrogen and breast cancer. I completely agree that I wouldn't say it's nonsense, but I would say it's a very specific subset of people who've had estrogen receptor positive breast cancer where their oncologist may not be comfortable with them being on vaginal estrogens. But again, I just wanted to, again, I said it's a theoretical risk, but if you look at the data is not compelling at all.
Okay. So would combining flow-ins with OAB medications, or if you were to combine flow-ins with an OAB medication, is that something that's safe to consider? Is that an option?
So, I mean, I have some patients who do that, and they tell me it does help, but we don't have any randomized trials comparing the two.
Okay. Is it something that you do have patients on it, so would you
I have
say
patients
just
on
go
it,
for it?
and they've given me positive feedback, but I don't have, again, I don't have compelling data. I don't have a randomized trial to prove its
Of course.
efficacy.
Okay. So patients with interstitial cystitis diagnosis and OAB symptoms, is there benefit with the use of flow-ins? And this, there are some, we hear from some practitioners who are unsure, right, when it goes to the acidity. Um, how would you navigate that?
Yeah, so I would say that for patients who have interstitial cystitis, I mean, they have a multitude of components. It could be pain, urinary symptoms, sexual difficulty, GI symptoms, depression, anxiety. If they have predominantly irritative symptoms, flowins can be helpful. But some of these patients can be particularly sensitive to a variety of things, even acidic compounds as well. So I would say that it is something that's part of my treatment algorithm, and it's something I do use in my practice for those with irritative symptoms.
Okay. Um, have could like SS so patients they're tapering off their SSRIs after very long-term use. Could this lead to OAB?
There's no evidence that shows that, saying that tapering off SSRIs would lead to that, but we don't have great data on it.
Okay. Yeah, it's just not something that they're actively looking at, right?
Exactly.
Okay.
We don't have it well studied.
Okay. Would you recommend a UDS for a refractory OAB prior to sacral neuromodulation?
In my practice, I typically do offer urodynamics prior to third line therapy, with the logic being is that um, when you look at a treatment like Botox, it has a risk of urinary retention, although it's very small. And there are some patients who have more sensory urgency. In other words, their bladder just becomes more sensitive at smaller volumes. And I use that to help differentiate who would benefit more from Botox versus signal modulation.
Okay, and since we're on the topic of Botox, I have a question here. What are your thoughts on patients trying flow-ins before Botox?
I mean, again, I'm always a big fan of exhausting conservative therapy. So I offer Flowins prior to Botox.
Okay. Any role of, hopefully I pronounced this correctly, duloxetine?
Duloxetine, yeah.
Duloxetine.
Yeah, duloxetine is an SSRI. It has data that's compelling for stress incontinence. They did go for approval through the FDA, but it wasn't approved in the US for stress incontinence.
Okay. What would you say is the place of cystoscopy in patient evaluation?
Yeah, so typically prior to third line therapy, or those who have other concomitant conditions such as microhematuria, gross hematuria, very refractory irritative symptoms, I do offer a cystoscopy. Usually at the same time I'm doing a urodynamics.
Okay. We'll just cover a couple more questions here. We're nearing the end of the hour. In relatively younger patients, say 50 to 65 years old, what percentage of OAB sufferers have urinary frequency urgency compared to the number of patients with urinary incontinence? Do you know, like maybe you don't have I'm assuming you don't have the exact number, but just from your practice, an idea.
I'm sorry, I didn't understand that. Can you say that one more time? I
Yeah, of
apologize.
course. So when you're looking at relatively younger patients, so 50 to 65 years old, what percentage of OAB sufferers have, so how, I would say a better way to phrase it is, in that patient population, how prevalent is urinary frequency urgency compared to like total urinary incontinence?
Yeah, so you're talking about dry overactive bladder versus like wet overactive bladder. And I would say the division between the two is it's probably like 60 to 65% dry versus wet OAB.
Okay. Are beta-3 agonists helpful when a woman has prolapse that is causing urge incontinence? Can you see prolapse in an ultrasound?
So prolapse is best diagnosed through a physical exam. There is, it is something we are working on the role of imaging and how we best image prolapse. Beta-3 agonists can be helpful in that population, but again, you'd have to determine if it's overactive bladder versus pelvic organ prolapse and address the underlying condition.
Okay. I think we're good. We're on a roll. You're on a roll, and we covered all the questions that everybody asked. So, yeah, I just wanted to say thank you so much, Dr. Chughtai, for the presentation and answering everyone's questions. It was great to have you on tonight.
All right. Well, thank you for including me, and I really appreciate it.
All right. Well, have a great evening.
All right, you too. Bye, guys.
Thanks, Dr. Chughtai.
Bye.